So I'll be talking about the refractive correction in keratoconus. The two main concerns in keratoconus is the progression and the visual rehabilitation. The progression is taken care of by C3R as told earlier, and I'll be talking about the visual rehabilitation. Why the topo guided ablation? Because it improves the asphericity of cornea, improves the refractive outcome, that is quality of the vision better than the quantity, and better tolerance to the contact lens or glasses. We have various protocols like Athens, Cretans, and Cretan Plus. The most popular one is the Athens protocol, which we follow. It is a topography guided partial PRK with combined with the CXL. In this, unlike the routine LASIK that we do for 6.3 mm optic zone, here we take only 5.5 mm optic zone, and we do not correct the full refractive error. That is, we correct only the 50 to 70% cylinder or spherical correction. And ablation of stroma should be less than 50 microns, and we do only for the thinnest pachy above 450 microns. The CXL is always accelerated CXL. The other protocols are the Cretan and the Cretan Plus protocol. In Cretan protocol, we do the PTK with CXL. PTK in the sense that it uses the excimer laser to remove the epithelium. The epithelium over the cone will be thin. So while removing, we take a little part of stroma also. And the other one is the Cretan Plus, which is PTK plus PRK plus C3R. Both have good long-term results. So coming to the topography based custom ablation treatment, that is the TCAT. The most popular, no financial interest, is the wave light in Alcon, and Schwinn platform we have the corneal wavefront mode. This is for the selective cases for the mild to moderate keratoconus with the thinnest pachy more than 450 micron, poor contact lens fit or unhappy patient with the glasses, and there should not be active ocular inflammation or central scarring. So this is a picture from this scan from the cirrus topography. The anterior curvature tangential, we can see there is a central cone and thickness is more, that is 514. So this is a best candidate to have a refractive correction if there is cylinder. And in TCAT, in the center cone, we can ablate the center cone will be the steeper area, and the area superior to it will be flattened. So the aim of us is to regularize the cornea, that is flatten the steeper area and steepen the flatter area. For that, we'll have two ablation area, that is at the center cone and the mid periphery, so that the central area between the both will be flattened here and here. So the area in between both will be steepened and the cornea will be more regular. So automatically the refraction will be more corrected. So TCAT gives us partial refractive correction. So while counseling, never counsel that we can completely avoid the glasses. Tell them quality of vision will be better and we will have refractive correction on regularizing the cornea. Saying about the quality of the vision, this will be the what the patient see before the correction, and after the correction it will be more clearer by reducing the higher order aberrations. Always the simultaneous C3R is better than the sequential C3R because there will be less post-op haze, more predictable refractive results of visual outcome due to ablation of the normal non-cross-linked tissue and less post-surgical recovery period. I'm just showing the calculation chart in Schwinn. This is a patient who had -4 cylinder, and the treatment modality we are taking it as a corneal wavefront mode, and patient had -4 cylinder, so I'm correcting only 2.5 cylinder. The patient had a pachy of 508, so it was safe, and I ablated only 26 micron stroma. This is the epithelial thickness, stroma only 26. The residual stromal thickness was 427. So patient improved to plano 6.9 with eliminating -4 cylinder. What if thin cornea and a descended cone. What I talked about the TCAT, better results are with the central cones. If it is a thin cornea and a descended cone, we have the TREC in place, that is topography based customized cone ablation of keratoconus with PRK with C3R. This is done in Schwinn platform since we can descend the point, pupil center. This was first discovered by Dr. Rohit Shetty from Narayan Netralaya. TREC is also done in the Schwinn apparatus in the PTK cam mode. This is for descended cone, thin cornea, and here the beauty is that we take only 20 micron depth of the cone and we calculate the cone area with the optic zone of only 3 to 4 mm of the apex. So we take only very little stroma, still have a great correction. Example, this is a cirrus topography scan. This is the cone area, so we measure the cone. This is the long axis, then we'll measure the short axis and offset radius, that is how much the radius is shifted from the center. The center radius is shifted from the center. We measure that and we put in our calculation sheet. This is the long axis, short axis, how much depth, and we can see how beautifully it coincides with the picture we made. This is the measured one in the Schwinn, and we'll ablate this area only, this cone area of 3 to 4 mm only. So this is a picture. I have done the epithelial remover by the instrument, and we descend the pupil axis and we ablate only this area, that is cone area that we have calculated. That area is only ablated. See, this area is only ablated, unlike the 5.5 or 6.3 optic zone. And this is followed by the accelerated C3R. So I'll be discussing about few cases. This was one case. So you can see the thickness was only 431, and we have a descended cone here. I measured it and did track. The pre-op vision unaided was 618. It corrected to plano 66. We cannot predict the outcome, but we can assure the patient that the better quality will be there, and on regularizing the cornea, we'll have a better vision. It's 2 weeks post-op, thickness is still 412. This is second case. It's also, we have a descended cone. I ablated only that cone area. Unaided pre-op vision was 618 parts, and this much cylinder and sphere she had 69, and it corrected to plano 69 unaided. This is the case 3, the same picture. She had 660 with she could not, no correction with any sphere or cylinder, and post-op she had 4-line improvement. So patient was happy. Second is the TCAT cases. It's little more central cone and thickness was 460. Unaided vision was 618. With this much cylinder and sphere, it was coming to 612. Post-op, it came to plano 69. This is also a similar case. Central cone and thickness was 512. So I safely did TCAT, and pre-op vision was 636 unaided. And unaided it came to 69. With correction, it came to 66. With 0.75 cylinder only. And this is the case I showed last time. It was a -4 cylinder for the patient. I corrected and it came to unaided plano. So the take home messages are: TCAT is suitable for the central cone and thicker cornea. TREC is for the eccentric thin cornea. Final corneal thickness should be above 450 microns with the epithelium. Both are followed by C3R, and these both regularize the cornea, correct the refraction, and have better contact lens fitting. Thank you.
Thank you.